A pleasure to see you join our conversation hosted by Braingels. So many thanks to Sam Alkan, who organized this, and to Kelly at Luru, who will be curating our Q&A session. So today we will hear about the opportunities and challenges of metabolic psychiatry, and we'll talk about the benefits of a ketogenic diet. As an investor in mental health innovations, what I like about metabolic interventions is that they work fast, potentially on millions of people. They are affordable, and they could help prevent mental illnesses as well as treat them. So, having made these bold claims, let's now have some reality checks from our distinguished panelists who have research, clinical practice, and startup experiences in this space. So Dr. Shebani Sethi is the CEO and founder of Metabolic Psychiatry Labs. She's also the founder of Stanford Metabolic Psychiatry Program and a professor at Stanford. Kirk Nylen directs the Bazooki Group's strategy for neuroscience research. And as for context, the Bazooki Group has funded dozens of research programs internationally. And Scott Fears is the chief medical officer of AMI Health and a professor of psychiatry at UCLA. So please, for the audience, start putting your questions into the chat for the Q&A session, which will happen in around 30 minutes or so. And I also encourage you to put in the chat any resources, such as academic papers, references, names of experts or startups in the space, or keto diet hacks. So without further ado, let's start with Shebani. You coined the phrase metabolic psychiatry. So please tell us what it is and who benefits. And if you could also very quickly cover what is a keto diet, since it's a proven efficacious intervention within the metabolic psychiatry field. So thank you, Shebani, for being with us.
Thank you, Marine, for having me and for the wonderful introductions for everyone here. So I'm an associate professor at Stanford, and I started a metabolic psychiatry program, and I'm happy to answer those questions. So metabolic psychiatry is really looking at metabolic solutions, metabolic interventions, pathways, and how that can improve the treatment for those with mental illness and serious mental illness specifically. So when we're thinking about, you did mention the ketogenic diet. Ketogenic diet is a higher fat, lower carbohydrate, moderate protein approach to eating, and it's been around for a very long time. It's not really a fad diet. It's something that has been around and used as a medical treatment with monitoring in the world of neurology and epilepsy for the past 100 years. And what we have done and people globally have done is look at how that can be applied in the field of psychiatry and mental health. In particular, we looked at the ketogenic diet in schizophrenia and bipolar disorder in a pilot study at Stanford that was published last year. And it was a study that was chosen by Stanford Medicine as the top 10 scientific advancements last year, which we are all very humbled by. It's a promising treatment solution for those with serious mental illness as an adjunctive, I would add, because the trial is not something that was compared to psychotropics directly, but it's something that has been is showing that it's helpful for patients, whether it is with their clinical global impression, which is what we measured as a standard measure in psychiatry for both schizophrenia and bipolar, whether they're metabolic markers like metabolic syndrome. We had 100% in that sense of change, reversal, that they no longer had metabolic syndrome after 4 months. So from steady start to 4 months down the line, they no longer had metabolic syndrome. They had an average weight loss of 10%. And visceral fat reduction of 36%, and a lot of other markers psychiatrically that we saw improvements on. But I also want to stress that metabolic psychiatry is not just a ketogenic approach or ketogenic diet per se, but that there are a lot of tools, metabolic tools, that folks are studying to improve mental illness. And we're really looking at, well, why are we doing this? So there is a relationship. It's not something that's absolutely new. It's something that also has been around for a long time, but we're putting things together and repurposing and revalidating treatment solutions and options. And so I will, I guess, pause there, but I have a lot more to say, but I'll pause.
Well, thank you for that. Just before we move on to Kirk and Scott, given the breadth of the tools, right, as you mentioned, not just ketogenic diet as an intervention, who does it benefit primarily? Are we talking about, patients with psychosis only, or are we also talking about people who may have milder anxiety conditions or OCD, PTSD? Is that relevant for that population too?
Yeah, so that's a great question. I think with more data and research, we'll know, exactly who are the responders versus who are not the responders. Just from preliminary data thus far, we know that it looks like there's a dose-response relationship in some ways with the ketogenic diet and compared to a low carbohydrate type approach. In those with psychosis or with bipolar, other diagnostic categories are being evaluated and studied at the moment. We do see that those generally with insulin resistance at study start have sometimes a better response. But this is very preliminarily that I'm saying that. There needs to be a lot more data for us to be able to determine who is actually going to be responding appropriately and well. So one of the things that we are doing, we just got IRB approval for a randomized controlled trial because we're moving from the pilot now to a randomized controlled trial where we're looking at ketogenic diet in not just schizophrenia and bipolar, but also major depressive disorder, and looking at deep omic profiling, so proteomic and metabolomic data, and epigenetic data. So includes microbiome and mitochondrial metabolite function genomic tests as well. So we're looking at all these factors so that we can see that if there is a difference between those that are responding better than others and why.
Wonderful. Well, that provides us a very good segue to Kirk, given the extensive research that you founded with the Bazooki Group. So, Kirk, can you please tell us a little bit more about how you approach funding metabolic health and mental health research and discovery, and specifically with some examples of the findings of the pilots that you've been running?
Sure. Thanks, Marine, and thanks for the opportunity to be here. We're very much in field building mode. So Shebani coined the term metabolic psychiatry, and it's a very new field. So I think the approach to a new field is different than an approach to a much more mature field. And that's reflected, I think, in the way that we approach it at Bazooki Group. So we have really three areas we focus on. One is research. So trying to build the evidence base for what I like to say, the who, what, when, where, and why of metabolic therapy and psychiatry. So who responds, who are better candidates than others, who do we think won't respond, those kinds of questions. We're supporting about 13 clinical trials right now. So the first two to have finished, the first one was Dr. Sethi's study at Stanford. Just about a month ago, Dr. Ian Campbell and his colleagues at the University of Edinburgh published a second pilot study showing very similar effects where we see full resolution of metabolic symptoms in participants, and we see a subset, usually a significant subset, achieve very significant clinical improvements. And I think one of the really important points to make here, we're not trying to claim that metabolic therapies are a panacea, but we know that people don't all achieve the clinical outcomes that they want to achieve on the medicines that are currently available. So we need other options. And really what we're doing is looking into other options that might benefit some people. So we have those two pilot studies. We have some larger randomized control trials underway. So there's one at the University of Pittsburgh with Mary Phillips' team. There's one at McLean and Harvard with Dost Unger, Virginia, and Chouinard. We have a new study that's beginning soon at the Mayo Clinic. There's studies at UCLA, UCSD, UCSF, international studies at James Cook University in Australia, Oxford University in the UK, and in my hometown here in Toronto, Canada. So there's a lot of irons in the fire, and in some ways we're waiting for the results of those trials to come in to really help us understand the impact and significance of this intervention in a serious mental illness population. But the important steps have been taken. The second way that we approach this is through capacity building. So part of that involves investing in companies. So for those on the call, if you know companies that are in the metabolic psychiatry space or even tangential to the metabolic psychiatry space and are interested in growing into this space, that's a company we want to meet and we like to talk with. We tend to see groups, like we see food companies, so people that are producing diets. We see digital health companies, so the Virta Healths and the Ona Healths of the world that are providing coaching and diet intervention to support their clients. Nutraceutical companies that are looking at different mechanisms that have been identified through the ketogenic diet and trying to add that into foodstuffs. There's a whole new field around exogenous ketones and the role that they might be able to play in supporting metabolic interventions. And then we see lots of technology companies, so the Abbotts of the world, the Dexcoms, the SciBios, who are looking to get into the continuous ketone monitor space. So, it's early stages, but I think it's beginning to flourish. I think there's a lot of potential here. We also have an awards program. So we just recently closed out our Young Investigator Award program to try and encourage young researchers and young clinicians to enter into this space. We provide financial incentives for them. And then one of the more novel things I think that we've been working on over the last year is something that we call learning health system, which is embedding research and care. So working with clinics, having them implement metabolic therapies in their clinic, and then having a research overlay where you have the right data streams, the right data infrastructure in the back end to do real-time analytics and understand how patients are faring with this approach, so you can make more real-time adjustments and insights. And one of the clinics that we're proud to be working with is My Health. So maybe I'll pause there and let you kick it over to Scott.
Thank you. You're helping me with my job here, Kirk. I mean, you're making the transition. Thank you so much. But just if we can pause for a sec, it's just for the benefit of our listeners. You mentioned a number of research programs. Can you give us a sense of what are the conditions that we're, addressing there? We've talked about bipolar, we've talked about schizophrenia, we've talked about major depressive disorders. What else is in the mix currently in the trials?
Yeah, the Oxford study is looking at ADHD with depression symptoms. There's a study that recently closed that's in publication now looking at depression in university students at Ohio State. And there's some really interesting pioneering work being done by Dr. Guido Frank at the University of California, San Diego on anorexia and looking at metabolic approaches to treating anorexia. So right now, that's the scope of what we're looking at. But our major focus is bipolar, schizophrenia, and major depressive disorder.
Wonderful. Thank you for clarifying that. I think it's important we understand there is a number of conditions and therefore people who could be benefiting from this research. Scott, it's your time to shine.
Thank you. Thank you. Thanks
so
for
yes,
inviting me here.
As Kirk mentioned, you are involved with My Health, and so you can talk to us a little bit more about the practical side, the clinical, the patient-facing experience, and also really trying to help us understand how we can deliver metabolic care in a scalable way.
All right, so thanks for the introduction. And well, let me say a little something about AMI first. So again, Scott Fears, kind of professor of psychiatry at UCLA, here representing AMI Health, so chief medical officer there. And we founded AMI Health about 3 years ago. And the reason we founded it was to really build what Marine was saying, which is scalable models to treat individuals with serious mental illness. And just to say something briefly about that is, we've got, maybe 5% of the population has some degree of very serious mental illness, either schizophrenia, bipolar, or really depression, anxiety, or things like borderline personality that are severe enough to almost completely, render someone, non-functional in social and work situations. And it's always been a frustration that there are good models to treat folks like this, but they're not scalable. And so on My Health, we founded it with our founders, Stas Sokolin and Sonia Garcia, about 3 years ago, with the goal to build these scalable models. One of our really clear focuses when we started this was the fact that the mental health system is largely a monotonic system that throws medications at folks. And with therapy, kind of weekly therapy, if you're lucky and can plug into that resource, but largely psychiatry is a practice of prescribing people medications. And as Shebani mentioned, a very, very common side effect of these medications is weight gain and metabolic syndrome. So it's kind of one of the great tragedies of psychiatry that someone comes in, with a lot of agitation, thought disorder, voices, and we put them on a medication that can be pretty helpful for the thought disorder or the voices. They stabilize, and then they go home, they sit on the couch, they watch TV, they gain 30, 40, 60, 80 pounds, they get diabetes, they get, some sort of, dyslipidemia and end up with heart disease. And it's well known that folks with serious mental illness have substantially lower life, 10 to 20 years of mortality, early mortality compared to others. So when we founded MI, one of the things we really wanted to make clear is that medications can be helpful and are important, but the care really needs to be wrapped around with things like diet, exercise, learning to plug back into school or work, healing families and social systems. And we're also brick and mortar in person. I believe very strongly that human beings need other human beings and community to get better. So we founded this clinic and then luckily connected, soon thereafter with Bazooki Group and Kirk and team, and really began a serious discussion about using metabolic psychiatry approaches to address the dietary interventions. And as Kirk mentioned, we've started a clinical trial to kind of create a research overlay for collecting data and being able to show what is improving: sleep, exercise, kind of what's everything that gets better, not just how do you feel, but just how does your overall health improving. So in this study, what we do is we give everybody an Oura ring. We actually provide, thanks to Bazooki's, we provide meals for 3 months. So we use factor meals. We researched a few different groups. Factor has a keto option. They're a good group. I don't want to endorse them specifically, but I will say that our patients have actually enjoyed the meals for the most part. And so, they get 3 meals a day delivered to their door. Well, they get a week's worth delivered at a time. And we do that over the course of 3 months. We titrate the meals down. So they start with 3 meals a day and then go to 2 meals a day and finally 1 meal a day. And then we have a dietitian in the clinic that is working with them, one, to kind of understand what is a keto diet, what's a well-formulated keto diet. I think Shebani mentioned that there's a lot of things that go under the rubric of keto diet, but there really is a difference between, a fad keto diet that, there's plenty of those on the web versus a well-formulated therapeutic diet. So we have a dietitian that's working with our members on that, and then also working with them over time to be able to start, preparing their own meals, including going to this, grocery store, find out what's appropriate for a keto diet, and then be able to prepare that, and then move them through over the course of 3 months to establish them on the diet. We're still in the preliminary stage, but I can say this with some confidence is everybody who's gotten on the keto diet has shown improvement. One of the biggest things we've seen is energy, kind of focus, energy, concentration, so that even if folks have some voices or some thought disorder, they're much better able to manage those They're much better able to sit in therapy groups and individual groups. Their energy throughout the day is much better. And so there's a general improvement. We have people that decrease the amount of meds they're on. And our experience is very similar to Shebani's in the sense that the concerns about the metabolic syndrome, the weight gain, the lipids, blood pressure, diabetes, all of that has improved in our patients. And other things as well. We had a patient with lifelong psoriasis, which cleared up when she got on keto. So that's kind of the experience delivering that. Now, maybe as we move on, we can talk about the scalability of this and some of the challenges to kind of getting health insurance companies to pay for it if you're using it in a medical model. But we have we have a dietitian, we have a behavioral health coach, as well as a whole team of clinicians. So we've certainly have a fair amount of creativity on the payer side in order to support this. Maybe I'll stop there and we can go to discussion.
Yeah, again, thank you, Scott, because you've also anticipated on the first question to start our Q&A part, really, which is, you each are obviously in the weeds of, implementing and researching this new field. What are the key challenges and blind spots that you have in your respective domain expertise? It is such an important, discovery, and clearly works on a number of patients, and also across a more metabolic health spectrum, right? Not just for people with severe conditions, but just to get better generally. So what are the key challenges? Who wants to start?
Maybe I'll start with one, because we all is kind of a group of us met last fall and really focused exactly on what are our challenges. One of them is the medical community struggles a little bit with keto. I will say in the past year, I feel like that's changed a lot. So a year ago, when I would mention the fact that we're doing ketogenic, therapeutic diets, it was often met with oh, that's a fad, or, some sort of a lot of skepticism, which is totally fine. I think skepticism is very appropriate in the medical field. But I will say now, when I mention ketogenic diets to a new group, when in conversation, it is much better received. I think now the general comment is, yes, I've heard about that, and I've heard some really interesting things about that. So I do think kind of the general understanding of it is moving. I will say that there's some important medical questions that need to be addressed. Probably one of the biggest ones I think about is cholesterol levels. So on a ketogenic diet, which especially an animal-based, which most ketogenic diets tend to be animal-based, although there are full-on vegan keto diets, so it's very possible. But generally, they tend to be animal product-based. And LDL tends to go up, right? So, we're following labs closely on folks, and most labs improve by far. Insulin, glucose, all of the, kind of the insulin-based pathways drastically improve, but LDL tends to go up. I do think right now the medical community has a bit of a one-dimensional view on LDL, which is LDL is bad, and you need anything that increases LDL is a problem, and our goal is to lower it. I do think there's some really important work going on to really address that and show that LDL by itself is not particularly a problem. If you have a lot of risk factors, that you really have to pay attention to LDL, but there are healthy folks who get on ketogenic diet, their LDL goes up, and evidence of vascular disease actually goes down. So this is early work, but I do think there's a fair interest in this, and it is moving towards showing, that LDL by itself is something that there's flexibility. I'll say this in terms of how we interpret it, but those studies take a while, and so it's going to be 5 or 10 years before we have a good, solid set of evidence to be able to say that with more certainty.
Thank you.
I'll maybe pause there as a problem and kick it over to Shebani and Kirk for other things challenges they they are aware of.
I think I'll maybe add to what Scott was saying and reiterate that with the LDL piece, that's something that very early on, over the last 15 years, all the patients that I see that I've prescribed ketogenic diets to have a set of data where we're collecting all these markers just to make sure over time how they respond to treatment interventions and then be able to tailor it specifically to their needs. And part of the advisory board, we have world-renowned lipidologists on our team to help guide us with those pieces. And I think it's extremely important that we look at all the data and collect all the data and work together towards finding, kind of the right solution for folks. But in terms of challenges, I think I will add that I think there's a couple. One is also with even being focused on nutrition or things that aren't necessarily part of standard of care and getting that reimbursed has always been a challenge. And working with payers, figuring out what would, one, be the value. How do you convince them that we're saving costs on their side? Part of the thing that we did when designing this randomized controlled trial at Stanford, which is also in collaboration with the company, the venture that we started, is to look at health economic data, look at the cost savings from, pre-intervention to post-intervention, and really look at all the, potential reduction in emergency room visits, medication side effects. Are they adhering to the medications? There are a lot of different ways to analyze health economic data that payers would be interested in exploring. So that's why we're trying to design it such that we're answering that question, especially in an adequately powered randomized clinical trial, which becomes really important, especially when you're thinking about, going beyond pilots and thinking about how to also at the same time convince clinicians that this is something that they should pay attention to or care about within our field. And usually that doesn't really happen until a study is adequately powered. And then you also have associations like American Psychiatric Association or others involved in building guidelines, or at least putting it in, kind of the eye of clinicians to understand. And so I think that's happening. I'm very positive and optimistic about that changing over time. And I think we need to build the research and evidence in order to, even when thinking about scaling, that's part of the solution. All these things are part of the solution. And I think policy-wise, there's also been a push to focus on nutrition and mental health. And I'm hopeful that that would be something that will be helpful for our patient population.
Well, thank you, Shebani. Kirk, unless you want to jump on the challenge question, I think it's about time we start to address some of the questions in the chat. And I think first, simply, and perhaps Kirk, you can handle this one. We have jumped the gun a little bit because I think we just need to, explain how it works. I mean, why does metabolic, what is metabolic health? What does it work on these conditions? What's the underlying?
Well, that was actually going to be I think one of the challenges we're facing is really around nutritional literacy. When you say metabolic health to people, it feels a little bit distant and maybe something that may or may not apply to you. But metabolic health is how your body uses the food and the drink that you put in it and converts it into the energy and to make your system run. We tend to think of the macronutrients, so protein, carbohydrates, and fat, which are the three main macronutrients. And we're taught which ones are good for us and which ones are bad for us. There's been a very strong narrative that fat is bad for you, carbs are good, protein's good. And I don't think that that's totally founded in the evidence. You can have too much of any macronutrient. If we had too much fat, I think we'd all agree that's bad. The same is true if you have too much carbohydrate. I'm a trained pharmacologist, so too much of anything can hurt you. Carbohydrates, when you consume them, trigger insulin, which is a hormone in our body. Insulin is required to allow cells to use glucose appropriately, so it's sort of a lock and key mechanism. And our body has a finite capacity to process carbs or to process protein or to process fat. And if you're having and your ability to process any one of those things is dependent on your genetics, your epigenetics, your environment, any other medications you might be on, and so on and so forth. Some people are very sensitive to the amount of carbohydrates they can consume, and they can develop metabolic syndrome as a result, which really is when your body's ability to process carbs, where insulin is no longer allowing sugar into cells, you develop high levels of insulin, high levels of glucose. These are toxic in the brain and they create inflammation. They can lead to lower efficiency of things like mitochondria, which produce energy in your cells and the function of those. So, and again, a lot of this there's a lot of inter-individual variability. So one of the ways in thinking about this is if you do have metabolic syndrome and your body is no longer effectively able to turn the food that you're eating into energy, is that you can rely on the fact that we're essentially a hybrid engine. Our body and brain can run off of both carbs and fat as energy. If the carbs that you're consuming are leading to inflammation and problems, then you can switch your fuel source over to fat. And it has a totally different pathway in terms of how it's used as energy. And that process, which has several different mechanisms associated with it, is what is thought to confer the effects that we see. So the ketogenic diet in epilepsy has been used since 1921. In people that don't respond to meds, 60% of those individuals will see a significant improvement in their seizure frequency. So it can have a very powerful effect on the way our brain runs. What we've learned more recently is that it can also have an impact on the way our brain runs if we have a serious mental illness. And there's no one mechanism. As a scientist, I like to think reductively, but that's not the reality of this situation. We know that what you eat affects how your mitochondria work and how they produce energy for your body to use so that it can run. We know it affects your gut microbiome. I saw the comments in the chat about holobiome and the work that they're doing, but that's a really important piece of it. We know ketone bodies themselves have direct acting effects in the body and in the brain. We know they can be metabolized to things. Recent research out of Stanford is showing that they can combine with amino acids in our blood to create ketone amino acid conjugates, which themselves can have effects in our brain. In fact, nature's most potent appetite suppressant appears to be a ketone merging with some free amino acids in our body. So there's several mechanisms involved here, and I don't think we should be thinking about what the one mechanism is, but rather how you can leverage the fact that we are essentially a hybrid engine and can switch our fuel sources to help us when our bodies aren't reacting to the foods we're eating the way we want them to.
Thank you for clarifying this. It is great. I think we have a number of questions around that, but it is also something we've claimed early on, right? That we could help prevent mental illnesses also with such an approach. So who would like to comment on why we can make that claim and how it would work?
I think I'll mention a little bit about that, and others can add. The data and research has shown colleagues of ours that have published papers in this area showing that those that have no previous psychiatric history but have insulin resistance, which is about 1 in 3 people in our country, have double the risk of developing major depressive disorder. There's also a study that showed that even with higher amounts of adipose tissue, so higher amounts of visceral fat and higher weight overall, led to an increased risk of psychosis, a developing psychosis. So this is pre-diagnosis. And we have also seen that insulin and glucose handling in the brain is altered in those with schizophrenia and bipolar disorder. This is before the diagnosis is made, before the first episode of psychosis is presented. This is there. So there is a relationship between metabolism and mental health that goes beyond just, will those with serious mental illness have higher rates of metabolic dysfunction? And if we improve that, then we're improving the brain. There are deficits in even the machinery in mitochondrial enzymes, respiratory chain enzymes in the frontal cortex that have been shown in schizophrenia. There's been certain enzymes with the TCA cycle, which is the cycle that we use to produce ATP in the very kind of beginning pathway, that is compromised. And so when Kirk was describing this switch from one metabolic state to another, and the fuel that we use, beyond glucose, and we go to you can burn ketones for energy, or you can burn lactate for energy. 100 years ago, in psychiatry, we had biomarkers of lactate and glutathione that were abnormal. So we know that there are these relationships between metabolism and mental health, and we are now looking at those cofactors, including hormonal. I completely agree with what Kirk was saying, that there's no one mechanism, there are many mechanisms. And even just looking at hormones like leptin and insulin, it changes and thyroid, it changes the cognition, changes the mood, changes memory. We see the direct impact of what we eat. And I will give one more example with that. Direct impact of what we eat and how that changes brain structure and function is that when you have something like insulin resistance or type 2 diabetes, you have a lot less gray matter and you have less hippocampal volume. So that's the area of the brain where we think about memory as pretty critical. So if there's a change in volume and there's a change in overall, you're getting a change in function, if that helps to think about it that way. I'd also say that there's research also showing that when we treat metabolic dysfunction like insulin resistance, there are improvements in blood-brain barrier leakage in those with bipolar depression. That was a study that came from Cynthia Cochin and her colleagues, showing that there's improvements in even being able to use the current drugs that we use for these illnesses. They work better when we treat the inflammation and treat the dysfunction. So it's not just improving, weight and insulin resistance, but we're also doing something in the brain. You can have abnormalities in the brain and not detect it in the blood peripherally.
No, I think that's very important. Thank you, Shebani, to clarify that. We have a question here that has come up a few times relating to a potential link between high levels of colon cancer and keto diet. You touched, Scott, on the cholesterol side of things earlier. Can anyone comment on that?
Well, I didn't look at the study, but yes, go ahead, Scott.
Yeah. Well, I did. I actually real quickly looked at the paper that was put in the link, and that paper, I think, kind of represents some of the confusion and problems around a lot of dietary studies. So that link was saying, high-fat diets are linked to microbiome changes, and these microbiome changes has been linked to colon cancer. I think we got to be very careful about making conclusions about the microbiome. I think the microbiome is incredibly important, and there's a lot of interesting stuff that is emerging on that. But I think definitive links between, all the different associations that are made with the microbiome right now, there needs to be some sorting out. But I would also add that, again, nutritional studies have been largely run through what I at this point in my career would see as a distorted lens over the past, 6 decades, right? I think a lot of these studies go in with the idea of what a good diet is, and then kind of identify, anomalies based on that. One important fact to notice is high-fat diets have been associated with colon cancer and heart disease and a lot of things, but all of these high-fat diets generally are in the context of high carbohydrate diets as well. So it does seem like high carbohydrates in the blood, and when they cross over into the brain, there's a sort of toxicity. Well, not sort of. There is a toxicity of these carbohydrates. So, and it has been mentioned a couple times here, is the blood-brain barrier is particularly sensitive to insulin resistance. Or another way to say that is the brain itself in the setting of insulin resistance is actually accumulating more damage than the rest of the body. The brain is kind of designed to soak up energy, in this case, carbohydrates when they're present. And so they tend to get preferentially pulled into the brain and concentrated there, leading to a fair amount of toxic damage. So my sense, again, I think there's a lot of questions to be answered about diets in general, but I would say we can't throw it all out, but I do think we have to look back at all of our understanding of dietary studies with a bit of a lens of skepticism, or at least kind of the ability to kind of recognize that there were many factors contributing to those findings that we now, a better designed study would be able to clear up. And I do think we have to hold those with a grain of salt. Recognizing, again, going back to this problem of the LDL, we do know that that dyslipidemia is associated with cardiovascular disease and colon cancer. So we're not throwing that all out, but I do think we need to come back with a more clear and fine-grained way to look at these things to really sort out what's happening. I know that's not a great answer, but I think that's just the state of nutritional science is that's where we're at right now.
I would agree with that. And I also would, I didn't look at the study specifically. I just clicked on the link and I don't see the original science paper yet. So a lot of studies also, they claim they're low carb diets, but they're not really that low carb. And like Scott was mentioning, the fat content usually also has higher carbohydrates in it. So that's part of it. How much fiber someone is also intaking is important, and what other, aspects of their kind of lifestyle is important as well when thinking about colon cancer and making that association or correlation so strongly. So I would say that I agree. There's a lot of, unfortunately, nutritional science research is not an easy thing to interpret, and it really takes someone with skill to do that. So I wouldn't necessarily just, be afraid or get scared with something that you see on the news, because it may almost always not be completely true. So I would just caution you to make conclusions on that.
To add to what Shebani said is nutritional science really depends on epidemiology of, saying what kind of diet have you been on for your whole life? And there really aren't any long-term diets where there's really well controlled. You can't do right. You can't say to someone for the next 50 years, this is what you're going to eat. And then you 100 people for the next 50 years, here's what you're going to eat. So doing well-controlled nutritional studies is just a very, very difficult thing to do.
Yeah, it's difficult. Also, I'm just going to add in one thing. We're adding on top of each other, which is fun, right? Because it's more of a discussion. I wanted to say that there are so many trials in cancer with ketogenic diets.
Yeah,
right.
Yeah, good point.
That's also something for the audience, I think, to be aware of.
Yeah, Kirk shared some of that reference in the chats. Incidentally, Kelly has very kindly created a sheet to summarize all the questions that have come through and some of the resources that you very kindly put in the chat. Thank you for that. After this call, we'll look at all that and try to see what we want to do with it. Perhaps another conversation, perhaps introducing people to each other. And to that effect, I was wondering if you could comment on the question of exogenous ketones. There have been a couple of mention of that. So if you could, perhaps, Kirk, you'd mention it first.
Yeah, I mean,
perhaps explain what exogenous ketones are.
Sure, exactly. Yeah, so there's 3 ketone bodies in the body: beta hydroxybutyrate, acetoacetate, and acetone. No, do not take exogenous acetone. It's called nail polish remover. Acetoacetate and beta hydroxybutyrate are interesting. There's been salts and esters of these molecules that have been created, and you can get them in powder form essentially and put them in a drink and drink them. Some of them taste like nail polish remover. Some of them taste good if they can manage to make them taste sweet somehow without adding a lot of sugar. I do think that there is a role for them. I think the evidence is very early and emerging. I don't think that you'll be able to, recapitulate the effects of a ketogenic diet using exogenous ketones. They may be something that help with on-ramps and off-ramps, whether it's an on-ramp and an off-ramp for the ketogenic diet itself, or an off-ramp for GLP-1s, or whatever. I do think they might have a role. There's some early work out of Stony Brook University and Harvard by Liliane Maruga-Perotti showing brain imaging using exogenous beta-hydroxybutyrate ketones and showing profound network restabilization in the brains of people with bipolar disorder, even with an acute one-time dose. So there's no doubt that these things have an effect on the brain. Maybe I'm a little old-fashioned, but I tend to adopt the saying, the medium is the message, and sometimes putting the effort in and committing to a change, however hard, is part of the process of getting to where you want to go. And although the diet can be a difficult change for some people, I think the mindfulness and the thoughtfulness that's put into how you're feeding yourself and its relationship to your body is not an insignificant one. And then, exogenous ketones, we don't know how they affect other, proposed mechanisms of the ketogenic diet, like the gut microbiome, for example. We would expect that they'd operate at the level of mitochondrial function, membrane dynamics that you see in the brain with ketone bodies that can have, in some cases, alcohol-like effects where they help restore fluidity in neuronal cell membranes. We know that there's pH-sensitive receptors in the brain, and some of those can be affected by changing the pH using ketone bodies and so on. But I'm skeptical whether you can recreate the effects of a ketogenic diet using ketones. I think of them as a tool that might be sort of adjuvant.
Thank you, Kirk. So we're 10 minutes away from the finish line. And we have had quite a number of really interesting questions. So again, we won't have time to go through all of them in the next 10 minutes, but we will endeavor to try to circle back to those and to the people who've raised those questions. One question here, which is probably quite a simplistic one, but just to understand, going back to, the sort of give us a picture of the patient's experience here. But so we have talked, and thank you for giving us a good explainer on the mechanics of it all. But if, say, you're a patient who suffers from both anorexia and bipolar, and or you're a patient who suffers from both schizophrenia and diabetes, how do we look at such therapies? Do they work? Are they actually being tested?
Yeah, I think there's a bit. I mean, I'll answer the latter and then the former in terms of the comorbidities. But someone with schizophrenia and diabetes, to me, I would strongly recommend, a ketogenic diet. Certainly I want to look at labs and risk factors and all of that. And so I won't make it as a blanket statement, but I think that's the individual that we know the most about, or, bipolar and diabetes, because we're addressing both the metabolic problems as well as the mental health problems. So that one to me is kind of an easy, let's take a look at labs and see if this is safe. But that's the person I think the data really supports that person going on a ketogenic diet. I think the individual with anorexia nervosa is a more complicated question, but Kirk did mention Guido Frank at UCSD, I think. He's a brave soul, because I think up front people would say, why would you ever take someone who has an eating disorder and, prescribe them a ketogenic diet? I mean, I've worked with a fair number of eating disorder patients, and dietary change with someone with anorexia is very, very difficult. What he's found, don't want to speak for him, but he gave a presentation at a recent conference where he was very enthusiastic about the potential advantage. I think he did it in weight restored individuals, although he may have done it in some folks that were a little underweight, or and what he found is they tolerated the diet very well. And again, I don't want to speak for him, but he kind of made a theory of anorexia. We might be thinking about it incorrectly, at least for some folks, where he's actually looking at the possibility that there's food sensitivities that we don't fully understand that well that actually generate somatic anxiety. It's uncomfortable for some folks to eat certain foods, and that's actually part of what leads to the anorexia. And then with the ketogenic diet, you're reducing those inflammatory and food sensitivities and allowing much more comfortable, ability to hold down food. And so he's actually found some promising results on that. I will say these are the interesting questions that kind of face us going forward, but it does feel like there's a lot of promising evidence for that.
Mm.
I'd love to add to the anorexia piece. I'm eating disorder trained, and I've treated a lot of patients with anorexia, binge eating, and bulimia. And I've done some research trials in the past with obesity medications and eating disorders. And I completely agree with what Scott was saying. I have seen patients with anorexia, and sometimes there's this, they're diagnosed with anorexia, and then it changes to bulimia, and it kind of goes back and forth. And it needs to ultimately, when folks are restricting their diet in the anorexia side of things, and maybe having like a low fat diet, that's very often with some, Stanford students and athletes. When you add the fat back in and go on a ketogenic approach, in animal-based food in particular, I've seen that be really helpful for these patients because, for example, a patient of mine had a period come back, menstrual cycle that was not regular before, that became regular when starting a ketogenic approach. It's not something that I would necessarily want to prescribe to every patient with anorexia. I think it's a very case-dependent situation, and we have to be really careful with anorexia. But the case with schizophrenia and diabetes is a bit more consolidated in the fact that we have evidence for a ketogenic diet being effective in obesity and insulin resistance and in diabetes. And we just have to make sure that it's appropriate for them medically. And so, those are the things that we would want to look at. And each person is different in the eating disorder kind of space, I would say. And I would be very careful and make sure that they also have the psychodynamics being addressed as well. And I've done a lot of DBT work with my patients, and it seems to be very helpful, I think, in this population. So.
And maybe just to build on that point, because I think it's really important, Shebani, is, the clinical labels that are applied to people aren't always linked to any sort of mechanism. So if you have a diagnosis of bipolar, it tells us nothing significant about your biology or the mechanisms of that disease. We don't have hard biomarkers that we use in diagnostics. So many psychiatric conditions are diagnosed behaviorally. So if you can accept that these are heterogeneous conditions, in other words, there's many different drivers that cause them, then it makes sense that some people respond to some treatments and not others. If the cause was the same in everyone would respond to the same treatment. So what I think the mission is before us, one of the most important questions we need to answer is, how do we tell if somebody has a condition that's driven by metabolic dysfunction? How do we tell if it's a condition that's driven by pure genetics or some other factors that are sort of involved to really help guide where we should be moving treatment-wise with these individuals. And one of the things we're learning in metabolic psychiatry is it's able to treat people that don't respond to the meds in all cases, but not everybody. So not everyone responds, and understanding who responds and why, in advance is really the holy grail for us right now.
Yeah. Well, that's where the future is leading us.
Yeah, and actually that's a good way to almost end our session, looking towards the future. So looking towards that common shared future, what are the progress that you'd like to see, each and one of you? Perhaps things we can help with here with the community, whether it's funding or partnerships, or identifying companies that are in this space. what would be your answer to that question?
I guess I'll start with that. I would like to give a shout out here to Sherry Sobrano for supporting us within the company and in our current randomized clinical trial. We are looking for more funding for the randomized control trial in the sense that we want to be able to do all the deep omic testing and also work with Kirk, the scientist you mentioned at Stanford who had the amino acid conjugate to the ketones. That's another thing that we'd like to add on. So we are looking for funding for that right now. And with the company, we're in a pre-seed stage and raising around this month. So if anyone wants to talk to me about any of that, please feel free to contact me.
Maybe I'd mention three things. One of them is other funders in this space that are looking to help grow the research and the clinical capabilities that exist out there. Certainly, I think Bazooki Group is one of the only funders dedicated to this space, and I think we welcome companies. So if this is an area that is of interest to you, then I'd love to chat with you. We want more companies in this space. I mean, we think if there's a flourishing of companies, then there's going to be a flourishing of solutions. And so the more we tend to do, pre-seed, seed level investments, but the more horses in the race, the better off I think we'll be. And then lastly, awareness. Most clinicians aren't aware of this as a field. They aren't aware that there is a link between metabolic health and mental health. And, my goal certainly is not that keto should be the one and only treatment for mental illness, but that it should be a tool in the toolbox, that people should be aware of it and they should know there's a time and a place that tool needs to be pulled out and that it will be really effective in some of the people that they're treating.
Thank you.
Yeah, I'd add kind of as a round out to that and I think there was a question about this, is about how to approach payers or at least pay for this treatment. And I think it's an interesting field because on the one hand, you can do this outside of a healthcare system, right? And just kind of set up I think there's a need for well-formulated keto diet approaches. I think there's a lot of keto approaches out there that are just all over the place, and it's not all protein. It's high fat with moderate protein and low carbs, right? So that's probably not what most keto diets are out there. But I think there's a space to actually build kind of a service, a non-medicalized service to actually make these diets available for folks, not necessarily focusing on a specific health problem, but focus more on wellness. Then I do think there's also the how do we get payers and policy to line up with the recognition that metabolic psychiatry or these metabolic approaches are actually quite useful, right? Most payers will pay for nutritional therapy for folks with diabetes or folks that are overweight, over some BMI. Those approaches tend not to be ketogenic, right? Those tend to be more, what you would have learned in the 80s and 90s. So I do, and they are limited to these kind of specific indications, diabetes and, overweight, obesity. So I do think there's a role in policy, Medicaid, Medicare policy, as well as other insurance payers to highlight the importance of addressing these things across a range of disorders and getting these things funded. So I think the paying for it, whether it's within the medical system or outside, I think are really important opportunities.
Well, thank you very, very much, Scott, Kirk, and Shebani. I've learned more than I hoped, and full of hope for this field, seeing more research, more precision research as well. And hopefully many more use cases amongst not just a population of ill people, but for the well-being of population in general. So thank you for that. That was very much my hope, that we would be able to articulate well what this is about and how it can help and who it can benefit. So thanks again for that. There was one question in the chat earlier to finish on a light note, which was who is on a ketogenic diet in this room? So I'll put my hand up. I have been on a ketogenic for some time. I don't know who else is. I hope some of our panelists are. Yeah, okay.
I'm a non-rigorous keto, but I like when I'm fully keto, I can tell. And then when I have my Belgian beers at night are not keto, so I fall off the wagon literally.
Yeah, something I'm familiar with too. Well, thanks again, everyone. And thank you to the audience who has raised some tremendous questions. Again, we'll do our best to try to address them in one shape or another. And have a good rest of your day or evening, certainly for me. And thanks again. Take care, everyone.
Thanks, everyone.
Thank you.